Okay, so today we'll talk about the drugs used in benign and malignant prostatic lesions. And again, most of the slides for the part of BPH are adopted from Dr. Dilip's lecture in previous years. But as I told you, that the malignant part was a new session last year, so they were made from scratch. Now I'll give you the references towards the end. So our objective would be, first we'll briefly revisit the anatomy of prostate and pathophysiology of BPH. And then we will talk about the pharmacotherapy of BPH. We have different treatment options, and that includes pharmacotherapy. And in pharmacotherapy, we'll talk about the pharmacological actions of alpha-adrenergic antagonists, 5-alpha-reductase inhibitors, phosphodiesterase inhibitors, and some other drugs. And we'll try to correlate them with their use in BPH. And then briefly we'll talk about pharmacotherapy of prostate cancer. Again, our major focus will be BPH. Okay. So I'm sure all of you are familiar with the prostate gland anatomy. Where is it? Okay. So it's located in very close proximity to the. Is it present in all human beings? And I'm just asking, I don't personally know, like, is there any female equivalent of prostate gland, or is there any, like, embryological origin? Is it something in the female anatomy, which is kind of equivalent, comes from the same source where the prostate comes? Are you aware? No? Okay, so you know it's the relationship with the urogenital tract, very close proximity with urinary bladder, just below it, so right below the neck of the bladder, or the outlet of the urinary bladder, and it's surrounding the initial part of the urethra. So hence its importance, okay? And as you can see on your left-hand side, we have normal structure of prostate gland, which is surrounding the male urethra, initial part of the urethra, and the normal looking urinary bladder. While on your right hand side, what has happened? The prostate gland has enlarged. That happens with aging. And because of that enlargement, it's compressing on the urethra, which is producing obstruction to the flow. And that increases the pressure in the urinary bladder, and that leads to hypertrophy of the retrostomachal as well. And at the same time, this enlargement is also compressing the urinary bladder as well, especially in the neck area. And that produces the irritation of the urinary bladder. So these patients have both obstructive as well as irritative symptoms. Though the obstructive symptoms predominate, but they can also have irritative symptoms as well. Okay, is that clear? And I'm sure you have done the pathology part of the prostate BPH. So you're familiar with the pathophysiology, why the prostate gland enlarges? Good. And have you done the clinical lecture? So you know the symptoms as well, huh? Good. That's good. So tell me what are, so we have like upper unit tract and lower unit tract. So what are lower unit tract symptoms are commonly known as GUTs? Okay, dysuria. Frequency. Urgency. Between. Anything from here? Okay, they can go in retention. Okay, good. Anything else? Somebody said something on the side? Nothing? Yeah, good. Was different infection or complications challenges, but like lower impact. All right. So again, so the symptoms that you were describing included both obstructive and irritative symptoms. So can you tell me which ones are obstructive? Dysuria is not obstructive symptom. Retention, dribbling, poor stream. So what happens with the obstruction? Whenever they have obstruction, because of obstruction, the first thing that happens, whenever they go to pass the urine, they have problems in initiating, starting the urination. So it takes some time. So that's called hesitancy. So they hesitate, like the urine hesitates to come out. So it's hesitancy. Then once it starts, the stream is poor. Okay, and they have to strain to pass the urine. And while they're passing urine, it kind of stops and starts. So that's called intermittency, which is not written here, but intermittency. And it takes longer time, so prolonged maturation. And even when they finish urination, they don't feel satisfied. They feel that there's some urine remaining. So feeling of incomplete bladder voiding. Okay, so there is always post-void volume, and this is what we do in investigation. We also look at what is the post-void urinary volume in the urinary bladder. So whenever these patients go for ultrasound, so ultrasound starts with the full urinary bladder. They do the ultrasound, then they ask them to go and void the bladder. They come back, and then again ultrasound is done to measure the post-void urinary volume. And again, when they are stopping, again there's difficulty in stopping. Again, there's a dribbling towards the end. So that's called terminal dribbling. And after that, once they're finished, after some time, again there's some dribbling. So that's called post-void dribbling. So these are all obstructive symptoms. And sometimes they can go in urinary retention. Okay. And then there are irritative symptoms which can happen with the irritation of the urinary bladder, especially the neck region. Now that can happen with the BPH, but that more commonly happens with infection, UTI, cystitis, or even if there is a stone in the urinary bladder, which is irritating the neck area. So again, if the stone is in the ureter, will that produce these symptoms? No. So irritative symptoms include urgency. So these patients, they feel the urge to pass urine. It's so strong urge that they have to run to the washroom. They will feel that's coming out, so they have to run. And during that rush, sometimes before they are able to get to the washroom and pass urine, some amount of urine leaks, few drops. So that's called, like, whenever the urine leaks is not under control, we call it incontinence. There are various types of incontinence. So when it happens with urgency, we call it urgent incontinence. Okay, so these patients can have urgency, urgent incontinence. This happens with UTI, with BPH. So whenever there's irritation of the bladder neck, frequency, because they are passing out small amounts of urine and they have to go again and again frequently. So this is the number of urination, like number of times they have to go to washroom. That's the frequency, and it is different from polyuria. What's polyuria? Yeah, so large amount of urine that happens with one example would be diabetes. There are other like diabetes insipidus and diabetes mellitus. So this is frequency. So this could be usually small amounts of urine, but many number of times, and sometimes they have to wake up at the night pass urine. That's called nocturia. Okay. Okay. So these are irritative symptoms, and besides there is dysuria as well, which doesn't happen usually with BPH, but with infection, like whenever this is cystitis, so they have dysuria as well, which comes under the irritative symptoms. As part of that, but usually happens with UTI, cystitis. Okay, so BPH patients can have both of these symptoms. Usually obstructive symptoms dominant, but they can have both of these. Is that much clear? So what causes these symptoms? We just discussed that, like, as you can see, the abnormal process to enlarge prostate, and that produces this like obstruction to flow and irritation to the neck region and hypertrophy of the reticular muscle, which again produces all those overactive bladder symptoms like urgency and all those things. And why do they happen? Because prostate grows with age. And why does it grow with aging? And then puts pressure on urethral circulation. So just I'm asking you, you have done in pathology, so I'm not teaching you that part, I'm just asking you, okay? I'll not give you answers, just want to know your answers. So what is the, what makes prostate go bigger? What age? Androgens. Androgen. You said androgen? So anything else? Just right. Right. What sort of right? High sensitivity. High sensitivity. Okay. Anything else? There may be some association, some risk factors like diet and some like metabolic syndrome and all these things. They increase the risk of BPH. But main culprit is androgen. So one thing has been bothering me, like this BPH happens when? The age goes away, as we age, and so what happens to androgens today? They go down.
Yeah, but it's just throughout the lifetime with more antigen release, there's more strict control.
No, but like you have much higher concentration, so is it like prostate enlarging at a higher pace in our younger years compared to like older years?
I think it's just a slow process. I think it's just a slow process.
So you're saying so prostate enlarging throughout our, like as we start producing androgen from our puberty, and it may be enlarging at a higher pace when we are young, and then like beyond my age too, like do slower pace.
As the androgens decrease with age, there will be an increase in the androgen receptor density in the prostate. So whenever androgen is left, that was basically.
So does that not, that's a very good thought, but does that not happen in other parts of the body? Then why do we get symptoms of androgen deficiency?
Because the prostate is a very constricted area, so.
No, but in any part, like, so the density of receptors, so we are supposed to other parts of the body, like the muscle of that. So we don't have like upregulation of receptors. Then low androgen.
We could have, but that would not be symptomatic. The reason that the prostate.
No, we get symptoms whenever the androgens are going down, we get all other symptoms of low androgen. That can start from like libido, erectile dysfunction, loss of lean body mass, increased fat, adiposity. They don't come back, unfortunately. So
We'll do our research and get back.
good.
Well, like a high amount of adrenergic receptors.
Adrenergic receptors, do they have a role in pathophysiology of BPH?
No, but they might have any number of it's gonna mostly go to the prostate since more receptors are there.
Adrenergic. No, see, but the adrenergic stimulation, I think, does it have any role in prostate enlargement? It has a role in the relieving the urinary obstructive symptoms. Because there are adrenergic receptors, alpha receptors in prostate as well as bladder neck, and we'll go over them. But that's for the symptomatic relief. Doesn't do anything to the prostatic size or hyperplasia process. So yeah, so we need to think about it. I don't know. So maybe something like maybe receptor regulation or some other thing goes up which sensitizes the prostate to androgens. So, but it's counterintuitive. I don't know why. Okay, so let's go to the real part. So we have what are different treatment options?
Androgen receptor.
Androgen receptor antagonist. Receptor antagonist.
On a 5-alpha reductase.
Yeah, so enzyme inhibitor, huh? 5-alpha reductase inhibitor, and before that we use something else before going to that enzyme. Alpha adrenergic blocker. Okay. So that's pharmacotherapy. There are a few other things. Besides pharmacotherapy, do we have anything else?
Yeah, surgery.
Surgery and lifestyle modification. Good. So the first thing that we usually do If the symptoms are not that bad and if the patient is not bothered by those symptoms, even they have symptoms, but if they're not bothered by those symptoms, we can do watchful waiting, because drugs also have their side effects and lifestyle modifications, and that could include decreased caffeine, yeah, exercise, and so you're improving your metabolic profile, but also like modify, like they are disturbed by nocturia, so they can take less amount of fluid before going to bed. Okay. So there are different various lifestyle modifications that can be done. And then we have pharmacotherapy, and that could include, as you said, alpha-1 adrenergic antagonists. Again, whenever we speak of BPH pharmacotherapy, we are talking about alpha-1 adrenergic blockers. And if we say selective versus non-selective, so we are talking about subtypes of alpha-1. Previously, when you're talking about like in autonomic, when you say non-selective, you're talking about non-selective for both alpha-1 and alpha-2. So they can work on both alpha-1 and alpha-2. Okay. And probably, and do you remember any drug? No, like which can work both on alpha-1 and alpha-2. Phenoxybenzamine, do you remember? Phenoxybenzamine. We don't use in BPH treatment now, but that was in the 70s, that was the main treatment of BPH. So it was not selective for alpha-1, So it would be non-selective for alpha receptor, so it would act on both alpha-1 and alpha-2. Obviously, it will have more side effects. You remember alpha-2 receptors?
They inhibit the release of reserve.
Yeah, so they are on presynaptic neurons, and they inhibit the release of epinephrine and norepinephrine. So phenoxybenzamine, but now we don't use it because now we have selective alpha-1 blockers. And then there are subtypes of alpha-1. So now when we speak of selectivity, so we're talking about subtypes of alpha-1. Okay, and when we say non-selective, we mean non-selective for subtypes of alpha-1. So here now we'll be only talking about alpha-1 blockers. Okay. So forget about alpha-2 now. Okay. So only alpha-1. So alpha-1 blockers. Then we have 5-alpha reductase inhibitors. And then we have like combination of both these classes. And then we have phosphodiesterase 5 inhibitors. They also have a role here. And occasionally we might use anticholinergics and beta-3 adrenergic agonists in case where there are like irritative symptoms are like more bothersome. Like if the blood is hyperactive, and then we can occasionally they can be helpful. And in the end, we have surgery. And there are various surgical options. You must have already done that. So that's not our scope today. So distribution of alpha receptors in the prostate bladder. So as you can see, they are highly they're present at high concentration in the bladder neck region, the trigone area, and the bladder sphincter, also in the prostate. So and we when we say alpha receptors, so we are talking about alpha-1 receptors. Okay, so alpha-2 are not here. So alpha-1 receptor subtypes. So we have alpha-1A, alpha-1B, and alpha-1B. Alpha-1A is present in prostate and bladder neck. Alpha-1B is present in peripheral vasculature, and alpha-1D is present in liver, spleen, and bladder. By the way, the stimulation of alpha-1 receptor, what does it happen? Like, what does it do? Sorry? Vasoconstriction. How?
Phospholipase C,
Okay. So which G protein? GQ protein, phospholipase C,
hydrogen not,
allicin diet.
not increases in calcium protein.
Okay, good. So in smooth muscle, so wherever it is, in those smooth muscles, it will cause contraction. So the alpha-1 receptors which are present on vasculature, they will cause vasoconstriction. Their stimulation that will lead to increase in blood pressure. And if they are stimulated on the bladder neck. Yes, no, they will cause contraction if they are stimulated. So it will cause urinary retention. So they will help us to like, yeah, so that's what happens with the adrenergic stimulation. So the sympathetic stimulation, like fight or flight mode. So you don't want to pass during that time. So all these sphincters are inhibited. So it will cause urinary retention. That's the stimulation, normal. So now if you use the blocker, what will happen? Yeah, so here in the prostate bladder neck, it will cause relaxation of the smooth muscle, and so that will relax the bladder neck and trigeminal areas of the sphincter of the urinary bladder is relaxed, as well as there is some relaxation in the prostate and scapula. So the compression on urethra is released, and that will help in urinary flow. Okay, so it relieve the obstructive symptom. So it will help in urinary flow. And if you stimulate, and the same drug, if it stimulates, so if it is acting on all subtypes of alpha 1, so it will stimulate alpha 1b on the vasculature. And what that will do, it will block, it will block alpha 1b on the vasculature. What will that do? Vasodilation. Decrease blood pressure. So it was hypotension. Good. So alpha 1 adrenergic antagonists are blockers. So you have non-subtype selective. So because a subtype of alpha 1 receptor, so we call non-subtype selective. So those which act on all subtypes of alpha 1 receptors. They are prazosin, doxazosin. I have written two names, but there are many others like prazosin as well. You might see that name commonly. So again, some books divide them based on their duration of action. So they are short acting and they're long acting. So prazosin is short acting, again in the same category, non-selective alpha 1 blocker, and prazosin and doxazosin are relatively longer acting alpha 1 blockers, non-selective. Okay, so they are non-selective. So they will what they will do. So they will one thing our primary objective here, they will relieve the obstruction and they will enhance the flow. So they will take care of the symptoms of the BPH. It's a symptomatic treatment. Okay, and it's not doing anything to the pathophysiology of enlargement of the prostate. Okay, it's not doing anything to the hyperplasia of the prostate. It's just relieving symptoms. The other thing it will do on the vasculature, vasodilation. It's blocker. Okay. These are blockers. That's why they are causing smooth muscle relaxation, both in the urinary tract as well as in the vasculature. Okay, so they are increasing the flow, whether it's urine or blood. So in the blood, they will cause hypertension. Okay. So if somebody has BPH and hypertension, and you can use this will be helpful. But if somebody doesn't have any blood pressure problem, then now we have discovered some subtype selective, which act only on alpha 1A, or which are more selective for alpha 1A. Again, all these drugs, which are we call them selective, you increase their dose, they have some cross reactivity, they act on some other receptors as well. So they are more specific for alpha 1A. That means they are working, they are acting on the alpha 1 receptors present in the urinary tract. So we call them uros. So subtype selective or uroselective alpha 1A adrenergic blockers, which are tamsulosin and saludocin. So these are the two. There are many others as well, but these are the two which are commonly used. And then we have one, alfuzosin. Alfuzosin, theoretically, it's non-selective. It's like non-subtype selective. So it should come in the upper category with the prazosin and doxazosin. It's short acting and it's like delayed, like longer release form as well, which is longer acting. But clinically, it behaves as a uroselective. In vitro, it's a non-selective, but clinically, it doesn't affect blood pressure. It affects only the urinary tract. So clinically, it's uroselective. That's why I have kept it here. Okay, is that part clear? So if someone So again, if they have BPH, the first thing we go with is alpha-1 blockers, and among alpha-1 blockers, you would prefer uroselectin, like tamsulosin and acetaminophen. These are the two commonly used, and fluoxetine can also be used. And if someone has hypertension as well, so then you can go with trazosine. Okay. Or someone was given a drug for the BPH and they have developed hypotension. So now you know which drug was given. Huh?
No.
Yeah, trazosine or doxorubicin. Huh? So we'll talk about different questions. So these are just questions that we will discuss during this session. So alpha-1 adrenoceptor blockers, they improve urinary flow and they relax smooth muscle in the bladder, neck, and prostate. That we talked about. And do not alter the prostate volume or serum PSA. What's PSA? Prostate specific antigen. Huh? So again, that increases when prostate size increases. So it does not alter the pathophysiology of the BPH. Okay, so it doesn't affect the prostate volume and doesn't affect the PSA levels. It's just a symptomatic thing. But it's a mainstay treatment. That's the first thing that we start with. And it does not alter the natural history of the disease. And then about blood pressure that we have just discussed. So how does these alpha-1 adrenergic antagonists, how do they affect blood pressure? So when we speak of non-subject selective, like trazodone and doxorubicin, which are alpha-1 blockers, they are non-subject selective alpha-1 blockers. So they act on all subtypes of alpha-1 adrenergic receptors, like alpha-1 A, B, and D, and they are indicated for hypertension as well for the treatment. Okay. And initiated, so and because as I said, they can cause hypotension. So even if you're starting somebody, whether they don't have hypertension or they have hypertension, in any case, you start at a low dose. Anything which can cause hypotension in the beginning, like are usually most of the vasodilators, especially someone who doesn't have hypertension, if you're starting them on this thing, so you start at a low dose and then you gradually titrate it up. Usually because with the first dose, they develop more severe hypotension, they develop dizziness, syncope. Okay. So this is called first dose phenomenon. So you start at a low dose and then you titrate it up. Okay. So you have to do this with non-selective ones like alpha-1 blockers. And then you have alfuzosin, tamsulosin, or acetaminophen. So they are subtype selective. They have more activity on alpha-1A. And highest activity on alpha-1A receptor is that of acetaminophen. And they are not indicated for the treatment of hypertension. And you don't need to do the initial dose titration. So because we are not worried about first dose phenomena here. So they don't cause dizziness or syncope. Okay. So is that part clear? Adverse effects, orthostatic hypotension, that's again with the non-selective ones like doxorubicin and trazodone. The dizziness can be there in both of them, tiredness, ejaculation problems, like because of this contraction of the vas deferens smooth muscles, so they can have an ejaculation, they can have retrograde ejaculation, nasal congestion or rhinitis, intraoperative floppy iris syndrome. Again, you don't need to worry about that. But that can happen if someone is on, especially those subtypes like tamsulosin and these things. If they are on that and they are having cataract surgery, so intraoperatively they can develop this problem where the iris can collapse. And to avoid that, if you're starting them on tamsulosin, and if they have cataract, they should have the surgery first and then start the drugs. If somebody's on the drug, and they should inform their ophthalmologist before going for the surgery. Now let's talk about 5 alpha reductase inhibitors, which we have finasteride, dutasteride. Okay. So regulation of cell growth in prostate, you already know this. So your serum testosterone, which is converted to dihydrotestosterone with the help of 5 alpha reductase. And then there are subtypes of 5 alpha reductase, type 1 and type 2, and then there's a type 3 as well. Again, even this year as well, I went through some literature, like there are different studies giving different viewpoints. So there was no consensus, but there's a type 3 as well, which is present in different tissues, including prostate, but also the skin and parts of the body. So this testosterone is converted to dihydrotestosterone, which is more potent, less potent? More potent, huh? And that DHT and androgen receptor complex stimulates certain growth factors, like some gene expression and growth factor production that increases the cell growth. So there's always a balance between cell growth and cell death. So this is different in favor of cell growth. But why does that happen in older age more? I don't know. So you should do your research for the part of pathology. So that leads to enlargement of the prostate. That's our current understanding. And that's why common sense says that if you block this enzyme, it should decrease this whole phenomena. The role of pile for reductase, etiology BPH is multifactorial. Prostate growth is regulated by androgens, particularly DHT, and it binds to androgen receptor and the stromal epithelial cells of the prostate. And it's going quickly because we just discussed this. And then when DHT binds to androgen receptors, it causes cascade of extracellular events leading to expression of genes and production of growth factors that regulate cell division for expression of the prostate. We just discussed that, huh? See, this is so soothing lecture. Some people go to sleep. So role of 5-fluororeductase in BPH, because as you said, it's more potent. It's around 5 times greater affinity, has 5 times greater affinity than testosterone. So and this conversion of testosterone to dihydrotestosterone happens through 5-fluororeductase. So if you block that with the help of those two drugs, menstrual and testosterone, you remember the names of the drugs? What are the names? Testosterone, yeah. So they block the conversion of testosterone to dihydrotestosterone. So the two isoenzymes or isoforms of 5-fluororeductase exist in the body, type 1 and type 2, and there's a type 3 as well, okay? And both types of 5-fluororeductase are found in the prostate and affect the stromal epithelial cells in the prostate. And now the one study that type 3 is also found in prostate, the other study when quoted about the organs did not mention prostate. So that's why I did not put it here. So in BPH, both isoenzymes of 5-fluororeductase are elevated. So again, these isoenzymes are elevated. Whether testosterone may be going down, but the isoenzyme in the prostate are elevated in patients with BPH. But why does it get why is it elevated? So the role of 5-fluororeductase inhibitors in the treatment of BPH. So 5-fluororeductase inhibitors block the conversion of testosterone to dihydrotestosterone. Okay. Are you sleeping? So 5-fluororeductase inhibitors reduce the action of androgens in the prostate, thereby shrinking the prostate. So these are the drugs which affect the disease process. Other drugs are affecting the symptoms. They are increasing unit flow by relaxing the smooth muscle. So they are just affecting symptoms. The group of drugs are affecting the pathophysiology and they are shrinking the prostate. So they are reducing the prostate volume and hence they are improving the symptoms and relieving the obstruction. So there will be the obstruction, but by this process. So obviously it will happen quickly or it will take time. It will take time, but this is the one which affects the progression of the disease. Hence, greater benefit is seen in patients who have greater prostate volume enlargement. Sometimes with slight enlargement, some people can have more symptoms. Others can have a large volume and then this may not have symptoms. So again, it varies from patient to patient. So those who have very large prostate, they will benefit more from these drugs. They are the only drugs that prevent or reduce disease progression. Like any drugs which affect the androgen levels. When I say only, so only in that category. So again, we use only when it comes to treatment of BPH, we usually use the 5-fluororeductase inhibitors, not other anti-androgens. Okay, there are other anti-androgens as well, which we'll talk about when we talk about cancer, inshallah, today within the next 10 minutes. So they also reduce long-term need for surgery. So they reduce the prostate size and prostate volume, and then hence they reduce the symptoms and obstruction, and they also reduce the long-term need for surgery. So 2-5-fluororeductase isoenzyme convert testosterone to DHT. So we have these two isoenzymes, type 1 and type 2, and there's a type 3 as well. And so finasteride acts only on type 2, while the dutasteride acts on both type 1 and type. So logic says the dutasteride should be more efficacious and potent, huh? Does that make sense? Because it's affecting both isoenzymes. Okay. Again, different studies say different things. So, and when once this is blocked, so DHT goes down and the prostate size come back to normal, or should reduce. So they did a study, a comparative study of dutasteride and finasteride, and they looked at the reduction in the DHT percent change from the baseline. So they started at baseline. So if you can see it with the finasteride over a period of 24 weeks, and then they stopped here, and then they went back to normal within the next 3 to 4 weeks. While with the dutasteride, there was a 90% reduction compared to 70%. And when you stopped it, it took longer time to come back towards the normal baseline. So if you look at the levels of DHT, dutasteride is more effective, but clinically, both of them are similar. Like the clinical outcome in both of the drugs is similar. Hypothetically, and yes, the dutasteride is more efficacious in reducing the DHT levels, but clinically the response is same. Yes.
That's right, also decreases the size of the prostate, right?
Yes, because it decreases the DHT. Both of them, they decrease the dihydrotestosterone. You just came in, I think. Yeah, we'll discuss these things. No problem. So both of these things, 5-alpha reductase inhibitors, we just discussed, this is important. Huh? So 5-alpha reductase inhibitors, they decrease the dihydrotestosterone level. They inhibit the conversion of testosterone to dihydrotestosterone, and that's why they reduce the prostate volume. They relieve the obstruction. Okay. Anything you want? Adverse effects would be obviously if you're inhibiting the potent androgens, so it will cause impotence, abnormal ejaculation, decreased ejaculatory volume, gynecomastia, depression, anxiety, and then there's concern about prostate cancer because 2 randomized trials show that it reduces the risk of prostate cancer compared to placebo, but at the same time it increases the risk of high-grade prostate cancer, and there was no survival benefit in giving this drug when it came to prostate cancer. So, and then we use combination therapy. Again, as you can like rationalize why combination therapy is more important, huh? Because one takes care of the symptomatic part and should be quicker in onset compared to this, and this takes care of the pathogenesis and takes longer time. So alpha blocks relaxes smooth muscles of the bladder, neck, and prostate capsule, thereby they improve the symptoms, flow rates, and relieve obstruction. And 5-alpha reductase inhibitors reduce action of the androgens, and thereby shrink the prostate size and relieve the obstruction and improve symptoms. And they did a study which showed the same things. So rational, again, as you can see, our objectives are like when we want to start these drugs. So if you look at individually, improvement of symptoms, both of them are doing this. Onset of symptom relief in 1 to 2 weeks, that happens with alpha-1 adrenergic blockers, not with the 5-alpha reductase. It takes around 6 months to see some benefit. Okay, so that doesn't happen with 5-alpha reductase inhibitors. Symptomatic progression, yes, both of them take care of symptoms. Not always. No, not always. Usually we start with alpha-1 blockers. Usually we start with alpha-1 blockers and we go with subtype selective. Usually, unless there's hypertension. Again, with hypertension, if someone is diabetic, has nephropathy, for hypertension, you would prefer the ARBs or ACE inhibitors. So again, you have to see from patient to patient. But for like theoretically and for usually most of the exams, what they want to test when they say, okay, somebody is BPH and hypertension, so they want you to go with those non-selective alpha-1 blockers. Huh? Otherwise, we'll go with the subtype selective like tamsulosin and silosin. And then if they don't have relief, then we add these things like the 5-alpha reductase inhibitors.
Stay outside. You have here from the beginning?
Yes, in the middle. But alpha one adrenergic blockers, they don't reduce the prostate volume and they don't reduce the long-term need for surgery. That happens with the pulmonary. So if you combine both of them, so you achieve all these objectives. Okay, so that's the rationale for combination. Now let's start with phosphodiesterase 5 inhibitors, which are tadalafil and sildenafil. Everyone knows sildenafil. Huh? Tadalafil actions phosphodiesterase 5 is present in smooth muscles of the corpus cavernosum, vasculature, prostate, and urinary bladder. And tadalafil has also been approved for the use in symptomatic management of BPH. It acts by relaxing the smooth muscle in the prostate and bladder. What are other clinical uses of
Pulmonary hypertension.
good and rectal dysfunction? And which one was the first brand? Right. Okay, so adverse effect would be headache, indigestion, flushing, nasal congestion, really prolonged erection, and there are certain contraindications and cautions, like you are not supposed to use them with nitrates. Why? Hypotension, because both of them will cause vasodilation and they can lead to hypertension. And so again, you have to be very, you should not use in patients who have cardiovascular diseases. You have to be cautious if you're using them with alpha blocking agents, because again, alpha blocking agents also lead to hypotension. Okay. And now, if somebody has overactive bladder, irritated symptoms are more. Also, I might take another 10 minutes. So, no, I don't want. Let's stop the recording. Okay, so I'm skipping this part. Whenever you time, you revise it for your own understanding. I will not. There's just one thing that you should know. There's no drugs in this. Okay, these are only when you have more irritative symptoms. In somebody with more overactive bladder, you might want to use occasionally. They are not commonly used in BPH. One category is beta-3 adrenergic agonist. The other category is anti-muscarinic N3 blockers. Okay. And they are more, but they can also go because they are relaxing the urinary. Those who have urgency in those things, but they can patients can go in retention as well. So those who have higher post-vital volume, you don't use them. Okay, so this much information is enough for you. They are known in. So let's very quickly talk about prostate cancer. Only 5. Okay. So one option is watchful waiting, active surveillance, and then we have different versions of radiotherapy, surgical, radical prostatectomy. I will not go into these details because we don't have enough time, and that's not our objective. So pharmacotherapy, we have androgen deprivation, which includes androgen deprivation therapy, which can be surgical castration or medical castration, which would be GnRH agonist, antagonist, androgen synthesis inhibitors, and androgen receptor antagonists, like androgen, anti-androgen therapy, and then chemotherapy and immunotherapy. So let's talk about androgen deprivation therapy. It's a bit dry part, so just bear with me. Aimed at decreasing testosterone production by the testes. It includes medical castration, surgical castration. Medical castration would mean giving GnRH agonist and antagonists to decrease the pituitary stimulation of androgen production by the testes. And indications are clinically localized high-risk prostate cancer as an adjunct to radiation therapy, locally advanced and high-risk prostate cancer and metastatic disease, which is stage 1. Adverse effects of androgen deprivation therapy, again, they are common to the whole class, so I'm just putting them together, then we'll go to individuals. So there's loss of lean body mass and increased body fat and decreased muscle strength, sexual dysfunction, loss of bone mineral density that can lead to fractures as well as osteoporosis, vasomotor instability, gynecomastia and other issues, fatigue, behavioral changes, and cardiovascular problems. And you know the stimulation, how the GnRH stimulate the anti-pituitary to produce LH and FSH, and how this LH stimulates creating cells to produce testosterone. Okay. So GnRH agonists, when we say GnRH, it could be LH. So this LH releasing hormones, so they also call them LH-RH agonist. So when you say GnRH, gonadotropin releasing hormone, so that's also luteinizing hormone releasing hormone. Okay, so LH-RH. Some books might mention LH-RH. Okay, but GnRH is a better term, so that's why I use. So agonist before light. One drug in that class. So this is GnRH agonist. Agonist should stimulate the production, but what happens naturally? It's pulsatile stimulation. So if you give continuous, it will cause receptor down regulation and decrease production. Okay, there will be transient increased production in the beginning, and then there will be decreased production of androgens. So it's a synthetic analog of naturally occurring GnRH, and mode of action is in terms of continuous or non-pulsatile administration. It will excessive pituitary stimulation leading to low GnRH receptors, low LHF secretion, low testosterone. In the beginning, there's a flare phenomena, which is transient surge in LH before the LH levels fall. And for that, you might use another anti-androgen like flutamide along with this, but you don't need to remember flutamide. Okay. Indications again, as we discussed previously, the androgen deprivation therapy, the prostate cancer and other indications. Again, you don't need to worry about them. Like breast cancer, you can myeloma. Side effects are described in androgen deprivation therapy, and the antagonist is degarelix. You remember this name? This is GnRH antagonist. So a synthetic GnRH antagonist. Mode of action, it competitively and reversibly binds to the through and blocks GnRH receptors in the pituitary. So decreases the release of LH and FSH and decreases testosterone. So we don't have initial stimulation of the hypothalamus pituitary relaxes, so there is no flare phenomenon. As opposed to, so you leuprolide. Leuprolide, you have initial flare phenomena, and this one you don't have any flare phenomena. And it leads to medical castration sooner. Indications again, as in prostate cancer, and side effects are similar to described with androgen deprivation therapy. Besides that, you might have elevated liver enzymes and weight gain. Then you have androgen synthesis inhibitor, abiraterone. Mode of action, again, the selective irreversible inhibition of CYP17 gene product, and that includes 17 alpha hydroxylase and C1720 liase. So it inhibits different enzymes, which inhibit androgen synthesis in the adrenal glands, testes, and prostate. So this is the inhibitor of 17 alpha hydroxylase. Okay. So it inhibits the androgen synthesis. There are many others. I'm just using one name, abiraterone, which is commonly used. Okay. Again, it's used as an adjunct to androgen deprivation therapy. There were two names that we did in the beginning, leuprolide and degarelix. So adjunct to that. And it's used in combination with prednisone because you see it's inhibiting some other enzymes in the adrenal gland as well. So it decreases the glucocorticoids. So you have to use it in combination with prednisone. And it also increases the mineralocorticoids, so it can lead to hypertension and hypokalemia and cardiac arrest. So these can be by possible side effects. And because it inhibits glucocorticoid production, so it can lead to renal insufficiency. So you have to use it with prednisone. And other side effects could include increased bone fragility because you are also using glucocorticoids, hypertriglyceridemia, hyperglycemia, and the AST. Now, the fourth category is androgen receptor antagonists. So these are receptor antagonists, apalutamide. So again, in this category, there was first generation anti-androgens, which included flutamide, which I mentioned that we use in the Christmas flare. It was very common, so you might hear this name with some clinicians or some books. I am not testing you on this flutamide, so you don't need to remember this name. You just need to remember the names which are in the title. This is the second generation apalutamide. Okay. And again, this is a non-steroidal anti-androgen competitively inhibit androgen binding to androgen and androgen receptors and function as androgen receptor inhibitor. Okay, so this is the androgen receptor inhibitor, apalutamide. Again, is an adjunct to androgen deprivation therapy in prostate cancer. and side effects, hypercholesterolemia, anemia, hyperglycemia. Okay, so these were the anti-androgen therapies, and besides that, someone who is disseminated like stage 4 disease, you might might need to use chemotherapy in some situations. And one drug that we will do today is docetaxel, which you already done purely. So it's a semi-synthetic taxane, it's chemotherapy agent like paclitaxel, which you did. So docetaxel similar. It causes, it inhibits depolymerization. So it causes the hyperstabilization of the polymerized microtubules. So there are drugs which inhibit the polymerization, there are drugs which inhibit the depolymerization. So it inhibits the depolymerization. So it decreases the mitotic spindle breakdown. So there's a mitotic arrest in the metaphase, so it does not proceed to the anaphase. So it's kind of mitotic arrest. So it's a chemotherapy drug. Indications adjunct to androgen deprivation therapy in metastatic prostate cancer. And there are other indications you don't need to worry about. Okay. And then you have to be, you should take care of the bone health of these patients. Okay. Okay. If you have any questions, just email me, but don't ask me which drugs are coming. So I've already told you. So just listen to the recording, you will find out.